Ajay, you can start.
Sir, please
Okay.
start.
Am I audible?
Yes.
Yeah. Good evening, all. Myself, Dr. Ajay Kohli. I, on behalf of Raigad IIP, welcome all of you to yet another academic session on behalf of our branch. As we all know, the recurrent febrile illness with respiratory complaints and other complaints has been creating havoc. Bringing a spate of illnesses in the pediatric population and creating fear. The fever is so high right from day one. It is creating fear in the patient. I am sure all this has created a lot of questions, not only in the parents' minds but in our minds as well. So this all this makes today's topic very relevant for all of us, not only for office President of Raigad, Dr. Vikas More sir, to take for this session. Over to you, Dr. Vikas.
Thank you so much, Dr. Ajay, for giving this opportunity. I am Dr. Vikas More, President IIP Raigad. At the outset, I am very much thankful to respected Ramakant Patil sir for giving us opportunity to work with Maha IIP, and this is a Maha IIP CME along with IIP Raigad. We all know that we are struggling a lot since last few days due to this viral havoc, and the as a pediatrician, parents, and children, everybody is suffering. So that's why we thought of this CME, and it has been organized within only one day. We thought it yesterday morning, and within one day this CME is there. So I'm really feel privileged to have such a galaxy of speakers like respected Yevle sir, Sudhir Sane sir, Pramod Kulkarni sir, Mohite sir, and our own Abhasya Patankar sir. And there are so many senior doctors like Dr. Prakash Vaidya sir, Dr. Minash Sheikh sir. Many people have joined, and I'm so fortunate to have this CME today. And we all know after the discussion, the thought process will be slightly clear, and we will be able to manage our questions more clearly. I request our respected Ramakant Patil sir to give his few words.
I congratulate Raigad IIP, a part of Maha IIP, to take up this a very important issue for practicing pediatricians. And I also congratulate them for choosing Dr. Abhasya Patankar, a able moderator, and galaxy of speaker and panelists who know both sides of the world very well as a practicing pediatrician and who are very high stature as an academician. Dr. Vijay Yevle sir, my friend Dr. Pramod Kulkarni, Dr. Mahesh Mohite, and senior pediatrician and guru Dr. Sane sir. And I know all those who are attending this CME will definitely have taken a message, and what to do and what not to do will be very important. Light will be shown on this viral epidemic. And I once again congratulate Raigad IIP, particularly Dr. Vikas More, President Raigad IIP, and Dr. Ajay Kohli, Secretary, and able team of Raigad IIP, which we have witnessed in last 2 years. The very academic and very good organization. And I thank you all for giving me an opportunity, and I am eagerly all ears for listening and enlightenment from all these 5 speakers. Thank you.
Thank you, sir. Now I request Dr. Abhasya Patankar sir to carry on the session.
Yeah, good evening to all, and thank you, Dr. Vikas. Thank you, Ramakant, for those kind words about me. It's really a burning issue when it has come to last 3 to 4 months, where we are facing many patients with fever, cold, cough. Only 3 symptoms: fever, cold, and cough. But it has made our life difficult because the number of cases we are seeing, it is really exhausting. And what comes to the health, I really don't know. But it's the time must be the solution, because few of the cases they have recovered, maybe with our treatment, maybe without treatment. And it has created a lot of mess in the minds of the clinicians, how to go about it. What are my challenges? If a person like me sitting at a rural place, and a person like who is sitting at a city and having great opportunity to investigate, it's a vast काय म्हणतो आपण त्याला फार मोठी दरी आहे. It's a vast difference. And going through this phase of managing cases at our place, rural area, and seeing how the patients are getting managed at tertiary care units, it's a big difference, and it's a big challenge even at our place how to cope up that. So this topic, actually, this CME has been organized in a very short time. The reason behind is I just had a talk with Dr. Mahesh Mohite sir. He said that now we are seeing lot many cases of fever, cold, cough, but there are certain cases which are getting complicated. Do you see such type of cases at your place? So I told upfrontly, I don't know, because us being a very primary type of a care center, we don't see such type of cases, but you must be seeing. So he tried to share one or two cases with me, and in that we thought our Raigad IP pediatrician along with Maharashtra, we should have such type of a CME where we can discuss our problems, our cases, our management protocols, and what we are going through last 3 to 4 months. And this the CME has been organized. It has been organized in a very ultra short time. That as Vikas told, it's in 1 day. So I really thank you, my panelists, Dr. Vijay Evle sir, Dr. Sudhir Sane sir, Dr. Pramod Kulkarni sir, and Dr. Mahesh Mohite sir for agreeing on this ultra short notice and taking out their very important precious time from busy practice, and at this hour of around 9:30 p.m., which is supposed to be a time to take the dinner. So I straightway, what is going to be the format of this CME? The format is actually, it's a case-based CME. But what we had planned is to give some messages through these cases as we progress to the cases. At certain point of a time, we will have discussions on these cases. At certain point of time, we can interact with each other. And if the time permits later, at the last, basically at the end, there will be a question and answer session, which I'll be taking question and answer session only which are given in the chat box, because there will be much time which will be left at the end of these cases. I have got Dr. Sachin Murade from Panvel, Chirayu. He has got one case, and I have got Dr. Meshram sir from Medicover. He has got 2 to 3 cases, and definitely Dr. Mohite sir also will be contributing if the time permits. So straightway I go to Dr. Sachin Murade for his presentation. He has got, he can share screen and start his presentation. Over to Sachin.
Abba, while Sachin shares his cases, can I make a few comments?
Yeah, please, sir.
That,
please
as you rightly said, dari hai in city and rural area. But let me tell you, my friend Sudhir, Mahesh, and even Pramod would agree with me that as more and more diagnostic facilities and labs are made available to big cities and pediatricians attached to corporates, clinician in them is getting lost gradually. And people like you who are not, the facility is not available so easily, the clinician is still alive, I would say. And management of the far, what is required, the need of our today is, I think, diagnostic stewardship. खूप साऱ्या गोष्टी अवेलेबल आहेत आणि नको तेव्हा काहीतरी विचारलं की माणूस जास्त बुचकळ्यात पडतो. त्यात इंटरप्रिट कसं करायचं म्हणून. आय एम शुअर सुधीर वुड ऍग्री विथ मी. तर कॉर्पोरेट मध्ये असून म्हणजे अनलेस यू ऑब्झर्व दॅट स्टीवर्डशिप, things become you yourself complicate things.
Why I had that comment, Evle sir, because I was just watching one of the webinars you only conducted. You were the moderator there, and I could able to see one case which was basically Dr. Tanu Singhal madam basically presented, saying that there was a case of adenovirus and ultimately a fever of around 2 to 3 weeks, and there was a pneumonia. And she could able to give some minimum globulin. And you also had a comment that it should not be extrapolated. And the fever went down and patient got discharged surprisingly at the end of 3 to 4 days. So this is something new, which is not possible at my age. Even if I do whatever I want to do, it is really not possible.
So that means you are doing commendable job. I must say those who don't have access to diagnostics are doing excellent job.
Yeah, this is something great for us. Yeah. So Sachin, if you are ready, you can continue. Sachin, can check the
Sachin, we can't hear you.
Webinar मध्ये
We can't hear you.
Sachin mute केलंय का? Unmute कर.
Sir, the mic is not working. I don't know.
सचिन सर अनम्यूट करा तुम्ही आणि बोलून बघा एकदा.
Not audible.
तर एक तर रिजॉईन व्हा म्हणजे व्हॉइस येईल किंवा मग हेडफोन वगैरे काही ट्राय करा सर.
Not audible.
नॉट ऑडिबल सर.
I would go to Dr. Sudhir Sane till the time Sachin gets his technical things cleared.
एकदा रिजॉईन होता का म्हणजे तुमचा व्हॉइस येईल आम्हाला. कॅन यू हिअर अस सर? सचिन सर कॅन यू हिअर अस?
त्यांना कॉल करा आबा सचिनला.
Vikas to be called. Till that time I'll continue with the discussion.
Yes.
I'll go to Dr. Sudhir Sane first. Sane sir, when we talk of Thane pediatrics, the first name which comes to our mind is Dr. Sudhir Sane sir. Such a great personality. What he says, he practices. He says that if there is no antibiotic, he will never write antibiotic. We say, yeah, there is no antibiotic, we will prescribe for Mexican. That is the difference between us and Sudhir Sane sir. That's the reason he is great in this. And he also agrees that not many cases he is also seeing nowadays. So, sir, kindly share your experience regarding last 3 to 4 months, what you are going through.
Yeah, actually, thanks, Abba, for those nice words. So we started, the first surprise we got was obviously that measles outbreak we started in, in Thana. The patients started coming in September, and then it lasted till almost December. And there was a surge of measles. And just 15-20 days following that, and the influenza and adenovirus patients started coming. So we have started, all of us are seeing lots of these patients, influenza and adenovirus. Some of them are diagnosed, some of them are clinically suspected and as classified as influenza-like illnesses. And I think there is tremendous variability of presentation. But one common thing is, in many of these cases, multiple family members are getting affected. And as in the discussion, I will tell you that some of the symptoms from family members also offer a clue to the diagnosis of a case in an index child. I think that is what I would like to say.
Otherwise, also, when some sort of a viral illness occurs, we always take a history that is there anybody in a family who is also suffering from cold, cough, or fever.
Correct.
But this usually is really quite common. But when first time you thought this is something different and which is not behaving normally, or the way we used to see routinely, when first time you thought?
So, see, the thing is that pharyngoconjunctival fever we have been seeing for many years now, and we have been able to diagnose them as adenovirus. But what is different this year is just the sheer magnitude of these patients. That maybe we would see during, adenovirus season, maybe 10 to 15 children in a month, maybe. Now we would see 10 to 15 children in a day of suspected adenovirus. So sheer magnitude. But I think that's not surprising, because post-COVID, I think if you see each and every viral epidemic that has come, it has come in a severely high magnitude. RSV came last year. It was tremendously severe. Influenza, the magnitude, not the clinical presentation, but magnitude, number of patients suffering because of influenza. All of us had in July, August, September. I think the whole class 8, 10 children were sick during that time. And I think the magnitude has been different. And this is the experience world over, that people are saying that the peak of the epidemics are very high, number of patients. Yeah.
Yeah, Dr. Vijay Sule, sir. Yeah, Sachin.
Am I audible now, sir?
Yeah. Please,
Yes.
Please go ahead. Yeah, please go ahead.
So basically, my case is 14 months female child who has presented with a very short history of cough associated with fever since 3 days, and she had a history of a rash over face and extremities since last 3 days, which was associated with fever only. It was a maculopapular rash associated with itching, and the child was having a history of lethargy since 1 day and breathlessness since 1 day. So looking at all these symptoms, it looks like some viral infection, like in a current epidemic scenario. And now she's developing breathlessness, means her respiratory distress is progressing since she is having lethargy also. So on examination, the child was having a tachycardia. Her peripheral pulsations were well filled. Her peripheral refill time was normal. CRT was normal. Her respiratory rate was 58, and there were mild respiratory distress. Although she was having mild respiratory distress, her saturation on room air was 98%, and she was having mild dehydration with bilateral wheeze and crepes, and systemic examination was normal. So moving ahead, now in a recent history, when we asked, there is a history of immunization 3 days back, and she received Japanese encephalitis vaccine. Subsequently, she visited a pediatrician who started her on azithromycin and levosalbutamol. In a past history, she had a history of a recurrent cough and breathlessness. In the last 1 year, in the last 6 months, she had a 3 episodes of this cough and breathlessness, which were one time it was associated with fever, but rest 2 times it was not associated with fever. And she was started on Budecort MDI with 100 mics dose. And there is a history of a seizures also during period of infancy, and she has received anti-epileptic almost for an year. And since last 2 months, her anti-epileptics were stopped. So this was her X-ray. X-ray is unremarkable except few infiltrations in right mid zone and lower zone. And her investigations revealed hemoglobin of 12.4 with a total WBC count of 18,400. Neutrophils were 62, lymphocyte 33%, platelets were normal, CRP was mildly elevated, that is 37.5, and liver enzyme SGPT was 25. So considering the current pandemic, we have started her on injection of pen Deolin nebulization. Her Budecort MDI we have continued cetirizine and ambrodidias. The child was not having fever during her hospitalization. Although she was having tachycardia during initial time and mild respiratory distress, she was maintaining saturation. And now the child is stabilized, no fever, no distress. So discharge on oral antibiotics, Deolin nebulization, Budecort, and this thing levosalbutamol, Levolin. The child was apparently all right, but again, she started developing fever. She was all right for almost 3 days post-discharge. And during hospitalization also, she was not having any fever, and her sensorium has improved. Now, since last 2 days, she was having high-grade fever, which was not responding to paracetamol. And she was having cough and cold, which was a continuation of previous symptoms. And the child was on Ocpen and Budecort MDI. Now, on examination, the child was febrile. She was having tachycardia. Her respiratory rate was 50. Mild intercostal retractions were there. Her CRT was normal. There was a bilateral wheeze with decreased air entry in left infraclavicular area with hepatomegaly was there. CNS-wise, she was lethargic, but she was responding to verbal commands. Then her X-ray was suggestive of left upper zone and mid zone haziness is there. So it was considered as a left-sided pneumonia. It can be due to secondary added bacterial infection. And her investigation revealed hemoglobin of 11.9, WBC of 8,490, with neutrophils of 34%, lymphocyte 57%, platelet 232,000, dengue and malaria were normal. Her CRP was 50 and urine routine was normal. On admission, she was having persistent fever. On the day 1 of fever. So we started her on injection ceftriaxone, syrup, azithromycin, and Deolin. Sir, can we have some discussion up till now on this case?
Yeah, sure. I will ask the panelists to kindly intervene. You can ask the question and ask the details also, or you can comment also.
Sachin, can we go back to the first slide and go slide wise? I mean,
yes, sir. So basically, she is a 7.6 kg female child. Initially, she had a cough which was associated with mild grade fever. Then she had a history of a rash also. Then she was lethargic and breathlessness. Her rash was maculopapular and it was having a itching. And in the past history, she had received Japanese encephalitis vaccine. She had received azithromycin also during this time. And there is a history of a recurrent episode. She had 3 episodes in last 6 months. And since 2 episodes were not associated with fever, it was she was started on Budecort MDI. And she had a history
Can
of
you please
a
tell
seizures
when
also.
did you see this child? Precisely at what time this year?
Sir, she come to us on day 4 of her illness.
No. Which month? Which month of this year?
She was admitted in January. January 16, she admitted.
Okay. And did she have cold at the time of presentation? Runny nose, cold?
Yes, sir. Yes, sir. She was having a cough and cold.
So basically, you have a child who has acute febrile illness, probably viral exanthema. Only thing is the rash was itchy. So very often we do see, sort of an allergic rash following an acute infection. Usually the maculopapular rash that one gets with viral infections are not very itchy. Since you are mentioning, I guess that itching was a significant component. Now, this child has had prior 3 episodes of respiratory complaints where she has been put on inhaled corticosteroids. Is there any family history of asthma?
No, sir. No family history of asthma.
Any previous hospitalization?
Yes, sir. She was hospitalized for convulsions during.
For convulsions.
Yeah.
Now, how many months has she been on this inhaled corticosteroids?
She was started just 15 days back, sir.
15 days back. But prior to that, she must have had repeated episodes. And that's the reason the pediatrician must have thought of starting inhaled corticosteroid.
She had a 3 episodes.
Again, any family history of respiratory illness just before this child? Any sibling or any elderly person?
She is the only child. She is the only child, sir, and there was no history of fever or cough cold in parents.
Sachin, what are the birth weight of this child?
Sir, she was 2.5 kg. She was delivered by LACS delivery in view of meconium.
So this baby was not normal to start with. It's just 7.5 kg at 14 months, where I would have expected this baby to be 10 kg.
Yes, sir.
0.5 kg at 15 months, I would have expected him to be 10 kg. What was the length of this baby? What is the length of this baby?
Sir, it was 78 centimeters.
It was length is acceptable. So this is some kind of acute malnutrition. So was she, she's having recurrent illnesses and with that wheezing. So was it really wheezing to start with? There may be something problem which is just aggravated. So, and you are giving typical history of fever, cough, becoming breathless on day 3, day 4. There is some kind of a respiratory complication coming in a previously not a normal child. So was there any kind of, we need to definitely consider a possibility of some kind of a immunocompromised situation by virtue of his malnutrition or something. I'll definitely keep that in mind. This is not a normal baby to start with. He had some problem to start with.
I would like to know about the dietary history, whether this
her diet was mainly milk-based, sir, because she was consuming milk only maximum.
And there is no previous history of hospitalization any time?
Only for convulsions, sir. It was a non-infective cause for her hospitalization.
No other infection mandating admission any time?
No, not no history of infection, but definitely, sir, cough, cold, and breathlessness was there 3 episodes in last 6 months.
Okay. That's a VZLRT, I would call it.
Yes,
virus associated with, that's all.
Yes, sir. Sachin, only thing surprising, I mean, her birth weight you said was 2.4.
Yes, sir.
So 24-72. At 1 year, you would expect the weight to be about 7.2, and with 3-4 episodes of acute viral or repeated respiratory infection, 7.6 at 14 months is not too bad, honestly speaking.
It's
and plus, you said
it's
very common in our, and then you said that the child's diet was predominantly milk based. But then what surprises me is the hemoglobin is 12.4, which is little unlikely for an exclusively milk fed baby. Invariably, they have. Unless the child was dehydrated. Unless the child was dehydrated. Was she taking any iron?
No, sir. No, iron was
no.
She was not taking any iron.
Counts are also very high.
Yeah.
5,27,000. Sudhir wanted to say something.
No, I was just making the same point that she must have been dehydrated because he said that she was dehydrated.
Just few more questions in line of that PID suspected by Mahesh. Is there any history of repeated candidiasis, diarrheal illnesses, or skin infections in this child?
No, sir, no history of skin.
Actually, I think these kind of cases, as I agree with all of you that we are seeing very common, and I wouldn't even think of PID right now. I mean, I would wait for the symptoms to evolve. But first day, I wouldn't. I mean, I think it's a great point that Mahesh has made, that think that there is a malnutrition, think that there's something wrong. But at present, I will take it as my usual outdoor patients of influenza-like illness, which is viral trigger wheezing now and needs supportive care. So I think that's what would be my care. I mean, the initial impression.
Again, with due respect to all the pediatricians, very often we say that in infancy, a lot of conducted sounds are misconstrued as wheezing. And at times we do tend to overuse bronchodilators, number one. I'm not saying that in this particular child, but in general, I've seen many children who are put on repeated bronchodilators oral. They're nebulized repeatedly. And because if you look at the X-ray that you have shown, though it is slightly overexposed, there is definite hyperinflation, and the infiltrates don't appear to be very significant. And thymic shadow is seen. So as I mean, this would be one of its, the common variety of recurrent, respiratory tract infection, virus precipitated wheeze. I mean, nothing beyond that, I would think at this point in time.
I think taking that further discussion further, Vijay, I think one thing that I just want to share, that in such a patient, when we give nebulization or any bronchodilator, either inhaled or nebulized, always note the response objectively, whether the child is responding or not. And that makes a whole lot of difference.
Absolutely.
Because an objective response will tell you that there is an element of bronchoconstriction and will dictate the continued need for using bronchodilators. Otherwise, we may not even further use the bronchodilators.
And Sudhir, at this
can I ask one question,
before
sir?
I forget, at this point only, see, I have learned over a period of time. I used to use cough syrups in the past, but since last 3 years or so, I've stopped using cough cold syrup in children below 3-4 years of age. I use bronchodilators, a lot of bronchodilators in this young children. And bronchiolitis, trust me, I use only saline nose drops. And why I do make use of you must try. There is a preparation called NasoClear Pure Health. It's a small cylinder and there is a mask. You just twist it open and the saline mist comes out. And it gives reasonably good relief. Especially we see a lot of bronchiolitis in this young age group, and even viral respiratory tract infections other than bronchiolitis, where you hear a lot of conducted sound, a lot of secretions, and it does help. And I mean, I would strongly urge, if you can stop using cough syrups in young children, especially 3-4 years, it would be great. And over a period of time, I mean, I have realized it really doesn't work. Sudhir, do you agree
taking
with
the
me?
point little further, I don't use bronchodilators also. No nebulization.
Not in infants, older children, I'm talking about bronchodilators.
Irrespective of
Infantolitis,
nebulization exclusively for diagnosed cases of asthma,
absolutely.
not at all in routine cases. And it doesn't make any difference at all. You admit a child and give no nebulization, no bronchodilator, no cough syrup. It actually doesn't matter at all.
Yeah.
But sir, whenever we see a patient who is wheezer, and in case we give nebulization, we do see response in these cases. Like
it's very subjective and it's a biased one. Let me tell you, none of the bronchiolitis has any problem without nebulization, or even except confirmed asthma, which is a very rare diagnosis. Let me tell you, if we revisit all the things, as Vijay rightly said about the family history, personal history of atopy, more than 3 episodes, febrile episodes, nocturnal, and dramatic relief with bronchodilator. Dramatic relief. That will be the only criteria. Anything going beyond 5 to 7 days is least likely to be asthma.
Again, coming back to this case, this is your standard, usual repeated respiratory infection with or without wheeze that we are seeing these days. And the only difference is in the past also we were used to seeing a repeated episode, but they're coming little more too often and very frequently. And typical history is, child is down with illness, recovers, goes to school and comes back in a couple of days again with some cold cough fever. I mean, this is a peculiar phenomenon that we are seeing for the first time in last several years.
The recurrent respiratory infection, what we talked about last year, we had this Andrew Bush talk where he said what we think of recurrent, there is nothing like a recurrent. You may have on an average 1 to 2 episodes a month, as long as there is no weight loss, as long as child is growing well, developing well, and in between the episode child is bang normal, just treat it as Valerie or recurrent virals and don't really bother about it. The books mention more than 3 episodes in a year or more than 3 episodes anytime in life. I think sometimes we need to be very practical. I totally agree. But at the same time, these recurrent wheezers, when you have a strong suspect, GINA guideline clearly mentions when you have a doubt of it, give us 6 weeks of controller. And if they respond, then continue for 3 to 6 months. If they don't respond, then you could automatically say that this is not likely to be an asthma. So it's there in the new GINA guidelines. 6 weeks therapy of control of inhaled corticosteroids.
True, Mahesh, but those GINA guidelines are referring to asthmatic children or multi-trigger wheezers or repeated wheezers. What Pramod and
no.
make a point.
This 6 weeks therapy, yes. That the bottom line, which is for these kind of wheezers, where you are not sure about steroids, which are not sure of asthma. When you're in doubt, then you give a 6 weeks trial and then take it further. Is there?
Thank you, sir, for a good point towards before starting steroids, at least we should give a trial of 6 weeks. Then subsequently, this child has presented again with fever. He was apparently all right for total 6 days, like considering the time of hospitalization and we consider a febrile period, almost 6 to 7 days has passed. And now again, the continuation of same symptoms, but fever has reappeared and the child was becoming lethargic again. So there was a decreased air entry in left infraclavicular region, and that is what we have seen on X-ray. There was a developing pneumonia in the left upper and mid zone, and subsequently, her counts were 8,500 roughly, and neutrophils were 34%. Again, lymphocytes were 57%. Platelets were normal. CRP elevated. This was the initial investigations which we have done, sir. And on this thing, the fever was continuous. Almost for 3 days, her fever was persistent and it was not responding to paracetamol. So now this is the area, like day-to-day practice, parents are very, they are very bothered about the fever and they are very anxious. So now the thing is that should we use mefenamic acid or ibugesic? Like that is the thing. How we can control or what thing we can do for such kind of continuous fever?
Though standard guideline don't mention, but ibugesic is a standard thing. I mean, I personally don't use it, but it is given in the books. After paracetamol, ibugesic can be used. Mefenamic acid is not there, but ibugesic is there in any standard textbook.
It's the worst scenario when you are allowed to use it. That too alternating therapy. But let me tell you, you don't need it at all.
I don't use it.
There is no fever. So we have to change our cutoffs of fever. The basic problem is we start the parents and we expect the child to get literally feeling cold to call it a control of fever. I put the cutoff of 101 to give antipyretic as well as to call the fever under control as 101 itself. Then there is no problem at all. Not at all.
I mean, can I say something?
Yeah, of course.
Which is what I'm practicing. That I use paracetamol and mefenamic acid. Paracetamol, both of them as and when needed basis. Cutoff will be 100 degrees in axilla. And what I want, I mean, I do use mefenamic acid if the paracetamol doesn't work within 1 to 2 hours, or if I have to, because on outpatient, I mean, I need my child to be comfortable for some time. So it is absolutely fine that, it actually doesn't make a difference whether you don't use even paracetamol. But as practicing, I always feel that practice is not only science, it's an art. And we need to entertain our patients and make them feel better, make them eat, make them hydrated. And for that extent, I think I use paracetamol as well as mefenamic acid. Personally, I don't use ibugesic because I had a very bad experience because of ibugesic, but it's personal. As books have mentioned that you can use both paracetamol and ibugesic acid.
Sir,
So
your
there in
comment
my
about
practice, I take 100 in the axilla as cutoff. I use paracetamol in good dose.
Yeah,
Occasionally, I tell them for first 40 hours, even they could use, we say 15 mg per kg 6 early. I tell them if
absolutely.
it is 2, I use a 4 early also. Because that phase doesn't last more than, say, a couple of days. So it doesn't give rise to acute toxicity. Secondly, I do counsel them. And I very clearly tell them that even though fever is that if the child is comfortable, don't aim at bringing it up to normal. Maybe it's, I understand it becomes difficult for young pediatricians to, counsel and comfort parents. At our age, Sudhir, they listen to us, whatever we say. ठीक है, वेळ लागणार आहे, वेळ लागणार आहे. Maybe बाहेर जाऊन they must be cursing us, but at least on the face they say ठीक आहे, वेळ लागणार आहे. सांगितलं ना डॉक्टरांनी वेळ लागणार आहे. So I avoid it, but occasional dose of ibugesic yes, if pushed to the wall. Mefenamic acid strict no, because Sudhir, very often it interferes with the clinical diagnosis. You do not know the pattern. They keep giving mefenamic acid. They keep on repeating it, and I'm sure you must be telling them that the dose and how frequently to use it. But very often I've seen that repeated dose of mefenamic acid, and I mean it interferes with your diagnosis, clinical assessment.
Yes, sir. So moving ahead, now considering the choice of antibiotics, already the child has received initially 3 days azithromycin. Now we have given of pain. He was on oral antibiotics. Now we have started with ceftriaxone. So should we have considered again starting azithromycin in this case?
Sachin, I think in this patient, we should try to hit on microbiological diagnosis. So let's see clinically what are the microbiological things that are there. This is 14-month-old child. And we would quickly again review this child's pneumococcal vaccination schedule, whether the patient has taken pneumococcal vaccine or not. Remember that this illness was biphasic illness. First 3-4 days of fever and cough wheezing. Then there was apparent normality for 6 days and then started having fever. This fever which comes at the end of the week of an influenza-like illness is almost always bacterial. And strep B pneumonia is very high contender for a differential diagnosis. This is probably strep B pneumonia, and I would think that ceftriaxone in our country for strep B pneumonia, community acquired, although this child was also hospitalized, would be a good choice initially. I think that would be my choice. I wouldn't add azithromycin up and I would only give a ceftriaxone. I think other panelists can opine. Mahesh.
Jim, tell me how this in between there are 6 days no fever, right?
Yes, almost for 5 days she was afebrile.
I want to know how was the child apart from fever? Was she comfortable, playful, feeding, doing everything fine?
Yes, sir. During hospitalization, she was all right, and that's why we have discharged. The most striking feature which the parents have noticed during second hospitalization was lethargy, because lethargy was their main
Let me tell you why I'm asking you this. Because initially she had 3 or 4 days of fever, then she was febrile for 5 or 6 days, and again she comes back with a symptom, and during those 5-6 days she may be on whatever medication. My first concern, do I really call it as biphasic? But generally biphasic, the gap is not that 5 or 6 days, 2 days, 3 days max. So 5-6 days, I wonder whether it's the same disease which is continuing, or I'm having something different as a complication or as an additional other infection. Now, how would I define it? If it is same disease, then in between, fever may not be there, but child behavior may not be good. Child may not be having eating, may not be active, may not be comfortable, and are carrying some kind of a subclinical symptoms all along. If that is so, then I have reason to believe that the previous infection, whatever it is not completely controlled and it's got complicated. If the child was absolutely all right in between with almost 6 or 7 days gap, I do think of something else. It may be picking up something else which is coming after 5 or 6 days. That's my approach in this case.
Correct, sir. So
Sachin, I would also, Sachin, can I make a point? Again, I mean, I don't think of a fresh onset infection on a child was just recovering of a viral illness. And
Correct,
here
sir.
you definitely have a picture of pneumonia, both clinically and on imaging, but not necessarily bacterial. Because if you look at, I mean, obviously you would 100% give antibiotic. I agree with Sudhir that I would not start azithromycin and ceftriaxone should be good enough. But I will call it fresh onset illness on a child who has just recovered
I
of a
agree
viral
with
illness.
Vijay. This is the first one was classic viral, and the second one after a gap of 7 is back-to-back infection. Though radiologically it appears to be bacterial, need not be bacterial at all, because the hematological picture is not at all suggestive of a bacterial. And these are the days when we get back-to-back viral infections as well, and it's not written. In viral pneumonias, not necessarily all will have to be interstitial. You can get alveolar infiltrates as well in the viral pneumonia. So it's not diagnostic of bacterial pneumonia. Especially with 3 antibiotics given over 7 days, I will think of something which is beyond all these antibiotics. Why should a child worsen already responded well to first line antibiotic and not responding to second line antibiotic without much of risk factors? No, this seems to be a second repeat viral pneumonia.
I just want to add here, Dr. Pramod, in the flow of the thing, that hematological picture is not looking like a virus. Believe me, Dr. Pramod, we have stopped considering that hematological picture as kind of a strong support to our diagnosis of bacteria versus virus, especially the present adenovirus. They are coming with very high counts, with 3-digit CRP, with counts of 18 and 20,000, without any localization, with some generalized picture. And now by kind of whatever experience we have over last 2 months, with almost 20-30 cases confirmed to be adenovirus, and those kind of count, we are seeing very high counts with high CRP on day 3, day 4, day 5, which turned out to be adenovirus or H3N2 or H1N1. So I don't think count is at all to be considered. It's a history which is very important. Right on day 1, very high grade fever, as Dr. Ambedkar says. Right on day 1, very high grade fever continues to be spiking beyond 5, 6, 7 days without any localization so far. It's it's a virus, and so 2 things which this virus has taught us. This virus is not like what I was taught 30 years ago in my. So you got a strong bacterial count, you got 3 days, 4 days, the child start recovering. This child doesn't recover. On 8, 9 days still spiking. Perhaps on a 8, 9, 10 day, start getting some kind of immune mediated complication. We've got a couple of HLH coming up with the infection induced. We have seen empyremas coming on day 3. Clearly adenovirus, which is proven. We have seen empyema with a ARDS kind of a picture. Another one went into myocarditis and they were sent for a ECMO. So those kind of things are coming on day 4, day 5. So I don't think on counts basis one can differentiate a virus and bacteria in the present epidemic at all. Count is just kind of a bone marrow stimulation due to high quality stress, and CRP just kind of a TNF mediated, interferon mediated response. Whether it is bacteria, virus, really does not matter. Don't differentiate those things. So I'm sure you will be giving antibiotic, but don't kind of rule out virus. It is still very likely to be virus with those kind of counts.
I fully agree with you. Counts and inflammatory markers are of zero help nowadays. They cannot be taken. For pneumonia, even the X-ray cannot be held as diagnostic. No investigation can differentiate between bacterial and viral or a co-infection. As you said, the adeno landing into empyemas, I doubt whether it was a co-infection or isolated adeno. How can we prove that and disprove that? So it's just a bystander. You might have bacterial pneumonia as well as adeno as well. So a non-worsening pneumonia is the point. I will consider non-worsening pneumonia with antibiotics given, non-worsening over few days is more likely to be viral. That is one of the points in favor of viral pneumonia.
Can I say one thing, Pramod and Mahesh? I think timeline of respiratory distress in a patient of viral infection is very important. If it comes in first 2 to 3 days, think of viral pneumonia. If it comes after 7 days, think of bacterial superinfection. As to the and we know that this happens. As to Dr. Pramod's kind of argument that how can a pneumonia develop bacterial pneumonia? This child has already received antibiotic, because this child had received antibiotic for viral illness when it was not needed to be given. And secondary bacterial infection with strep pneumonia is not uncommon. I think let's move on to the case further.
Yeah, sir. Now we are on to day 3 of her illness. Still, she is running continuous high-grade fever. And she had a history of loose motions also. And subsequently, we repeated count on again. So now the hemoglobin is 11.7. Now WBC count has dropped down from 8,490 to 4,700. And it was more of a lymphocytic predominance, and platelet has also dropped down to 1,49,000. During her first hospitalization, platelet count were 5,37,000. Now the platelet count has dropped down to 1,49,000. And already we have done NS1 and dengue, which was negative. Her CRP was 28.3. We again did her liver enzymes, which was showing hypoalbuminemia, hypoproteinemia 5.7, and SGPT was 60 and SGOT was 112.
Ferritin.
Ferritins are 831.
So on a higher side, you need to keep check on that.
Yeah, sir. And her COVID antibodies were strongly positive. Fibrinogen was 236. Now the child respiratory distress was persistent, and now she started desaturating. We have started her on airbo support, but at this point of time, already we have given ceftriaxone for 3 days. Now, should we consider upgrading antibiotics, or should we think of something else?
I will upgrade, definitely.
Sachin, I wanted to ask you what efforts for bacteriological isolation you have done for last 3 days and in last 7 days.
Actually, we have sent blood culture.
Okay.
And subsequently, we sent her respiratory panel also, sir.
From where?
Infection laboratory.
No, from where means nasopharyngeal.
Nasopharyngeal swab we have sent.
Okay. Nasopharyngeal swab and blood culture you sent.
Yeah,
and
yes,
any result in first 3 days that the
no,
child
sir,
is
no
deteriorating
result.
now? No result.
But only thing which we got positive on day 3 of her illness was adenovirus. This PCR was positive.
Okay.
Can I come in here, Sachin?
Yes, sir.
Out of this outbreak of adenoviral infection that we are facing these days, in such a child of pneumonia which has occurred on an underlying viral infection or just preceding viral infection, as Sudhir said, strep pneumonia and staphylococci, these are two common bugs which complicate underlying viral infections, lower respiratory infection. And if the child who started on ceftriaxone doesn't respond, deteriorates, and you have a patch, I would certainly add vancomycin in such a situation.
Correct, sir.
Yeah.
Sir, given a choice between vancomycin and linezolide, that is the another question, or that is the common dilemma which we face during our day-to-day practice.
So there was a belief in the past that vancomycin is better in bacteremic illnesses, but there are a good number of people which talk about even linezolide acting reasonably well.
Yes.
And so,
but Vijay, sitting in your chair, you should not promote linezolide, because that's for the box.
I'm answering his particular question between vanco and linezolide. But as far as well, spare linezolide and vancomycin would be the choice. Yes. Sudhir wants to say something.
Yeah, Sachin, I think before considering upgrading antibiotics, because we have thoughtfully started on ceftriaxone, quickly look for some other issues. Are there any local complications developing in this child? This child's respiratory distress is increasing. And so is the child developing pneumonia, or for that matter, even empyema or lung abscess? Sorry, the child is already having pneumonia. So think of immune-mediated complications that is occurring, and you have shown some hint to that immune-mediated complication occurring because this child has also liver enzymes which are increasing. And we need to explain that. So I think of adding antibiotic, but don't be happy only by adding antibiotic, because possibly we have not hit on the proper cause of the illness.
Sudhir, on the background of viral infection plus such a pneumonia, that SGPT of 112 and SGPT of 60 would really not bother us so much.
No, but
do you agree with me?
I absolutely, but I think still that means I will be, see, at present, at least my diagnosis was bacterial pneumonia here, and I wouldn't expect SGOT, SGPT to be high. And if it is high, my counts are dropping, I would be little uncomfortable. I will be little uncomfortable.
Yeah, that point is well taken. Yes.
Is immune-mediated complication occurring? And I think, Sachin, you also thought of all that, and because I could see the list of investigations that you did, but you should think of that. Okay.
Yes, sir. Yes,
See,
sir, definitely.
interestingly, in this case, you got this facility for virus. Maybe 5 years ago, even in the corporate center, this was not so freely available. And I was Abba sitting at Mandgaon probably don't have the access to this. So for him, if he get this kind of a condition, is justified in kind of a giving at least one step off ahead and then may forward it. Because if it is virus as it is, you're not going to do anything. And if
No.
at all, what you're going to treat is bacteria. So how you're going to look at? So we need to be giving kind of a guideline for the whole masses. For a corporate and for a city population, it's okay. For a peripheral population, I think it's going to be a nightmare condition. We need
No,
to be
I want to pose a different question for Sachin and all the other panelists. Is that what is the interpretation of this adenovirus? You think that it is cause of this pneumonia, or it is a bystander, or it
bystander.
is
Yes, sir.
it is
That is
both
what.
or
So,
it
No,
is
only.
so that
On-
means by having the facility of adenovirus, as Vijay was saying, we have probably confused it. So possibly it was the first infection adenovirus, and
Sudhir,
now, okay.
Sudhir, I want to put here whether first was a virus and this is HLH.
Okay,
The second one is only HLH. It's not
possible,
bacterial at all. First
possible.
was the adenovirus which you picked up now, and then that can explain this as the HLH as a complication. This is not any infection only.
Only thing, Mahesh, I think agree, but HLH with absolute normality in 5 days on ongoing viral infection would be odd. So your point that you are asking, Sachin, is very valid there, that when this child was all right for 5 days, was he really absolutely all right from all the senses? If that is so, then adeno going into HLH looks unlikely. Right? On the same illness going into, because the child should not be totally all right unless he has been given steroids. Half
So
Yes,
dose.
sir.
it is a very difficult question to answer whether this is a bystander adeno or
Absolutely.
a true adeno. It's extremely difficult.
Absolutely.
Now, see, if it was adeno, we know the DNA can persist for ages and it can come positive. And so previous infection was adeno and the child recovered because he had no fever in between. And this is a fresh onset bacterial infection on a lung which has lost its immune defense mechanisms is a possibility.
So, sir,
Or
like
some
we got a
infection which is complicating.
adenovirus and we are on an antibiotic, we have upgraded, but still the fever is persistent. So, again, what to do?
I will not call it as HLH. See, all these clinical syndromes, they have clear-cut definitions. Unless the child's reports and clinical condition fulfills the criteria of HLH, these are just trends. You just cannot put on paper that this is positive in favor of HLH. So I will not think it is suggestive of HLH. I think we are over-diagnosing HLH and suspecting HLH nowadays too much and intervening unnecessarily. Here I will think of, but I will not label this at HLH unless he fulfills all the criteria.
Sir,
So I
on the back,
believe when Mahesh said, Mahesh meant that you would keep HLH in mind and observe the course. We won't call it HLH at this point of time. Correct, Mahesh?
I agree, absolutely.
Yeah.
You won't jump onto it. So this is a
Yeah.
case where I
You
may
will
go
keep
for
it in
bone
mind.
marrow.
Yeah.
I may do a bone marrow. I'm seeing already biocytopenia coming up. I'm seeing the ferritin climbing up. I don't have a reason for this fever to come up. I've got a hepatic parameters already going up. I'll definitely go ahead and do a bone marrow as well just to confirm it.
sir,
There's nothing,
actually,
I mean,
fever was persistent for next 2 days. Continuous high-grade fever was persistent. Now, we again repeated the things. Again, the counts are going down. Platelets are going down. Her SGPT is coming up, rising, and now ferritin has increased from 2595 to 831 to 2600 almost. Now my question is, should we consider IVIG or antiviral medication at this point of time, or should we
Steroid.
consider bone marrow and steroid?
Bone marrow and steroid. My take will be bone marrow and steroid in this case.
I'll be little hesitant in this adenoviral outbreak of using steroids.
Yes, sir.
See, first of all, the ferritin is climbing, SGPT is climbing, but child is on well under control. You have taken the controls in your hand. He's been put on support.
Yes, sir.
And I would still, wait. And maybe if at all, I would use IVIG and not antiviral. I doubt if it has any role at this point. First of all,
Which antiviral? Which antiviral, by the way?
No.
Which
Sir, actually,
antiviral?
cidofovir,
No,
lactate
cidofovir, no.
There is no proven
No
role.
pseudopower.
Actually,
No,
there is a
see,
lot of
again-
discussion going around this medication. It is used in immunocompromised persons, and it is having nephrotoxicity as one of the major complications.
Correct.
And we don't have any pediatric thing to support to give this antiviral medication. So we have taken a safer option, that is we have started on
IVIG.
IVIG. Now, after giving IVIG also.
But Sachin, even just a point, I would not jump to giving IVIG on this particular day. I would have still waited, looking at the overall response of the child.
See, when
I
there
don't
is
know. I
no
mean,
organ
whether-
Actually,
system
already
dysfunction,
we are on
the
5th
child
day
is
of
not
illness.
worse. Why to think of HLH at all, establish HLH and treat it preemptively? I would go for either a steroid or IVIG. None of
just
it.
wait it out.
I have one suggestion here. I mean, a very, very interesting case, Sachin, that you have presented. See, one thing that we have got is only adenovirus as a microbiological or bacteria, kind of involvement. We do not know anything more about this adenovirus, whether this is there in the blood or any sterile site. Then it would be much more important to consider IVIG or active viral replication that is causing. I think the illness doesn't tell me that this is viral. So antiviral is out. IVIG, what some experts have used IVIG in adenovirus, but that is provided it has very high adenovirus antibody titer. So IVIG you need to check and give. So we don't want like what we wanted to do, say, I mean, IVIG is probably not going to work in this patient. It's not a good option. I think doing bone marrow, I think, and looking at whether there is really HLH would be the thing that I would really do in this child at this stage.
I think
So another
IVIG
thing-
is like a COVID convalescent plasma. And we have
Yes,
gone recently through the COVID, and all kind of drugs came and went without any kind of evidence. In the heat of the moment, all of us have used everything. At the end of it, we still don't know what worked, what did not. There are reports which are coming that remdesivir saved, and there's coming very aggressively. IVIG, people have used convalescent plasma. We don't know what is the advantage. Pediatric, they are not used. So I think we are just on the learning curve. It's very difficult to say dogmatically, but this whole picture definitely looks like HLH to me. A bone marrow will be definitely justified. That confirms it is so. Then we'll have to treat him on the lines of HLH. The whole
Yes,
picture looks like HLH.
No, Mahesh, with a count of 2,776% lymphocyte, child well under control, why would you hurry up with IVIG also and bone marrow also? Why not just wait it out?
Sir, on the background of MISC, we did echo also because her urine protein create ratio was on a higher side and her ferritin were
4.3.
rising up
Okay.
and COVID
Okay.
How
antibodies
does
were
pneumonia
coming
fit with
positive.
MISC?
So there is something
Pneumonia, how does it
immunological
fit
which is
with
cooking.
MISC?
Till you give steroids only.
No, Sachin,
Hmm.
the thing is that, see, again, like Pramod made that point very nicely, that before labeling these clinical conditions, we must see whether they are fitting exactly into the clinical diagnosis. One of the most important thing in clinical diagnosis of MISC is after exclusion of all the possible causes. You have adenovirus there. How can you say this is MISC? I mean, we should be extremely careful without
Considering the safer option, IVIG against steroids, doing an intervention of bone marrow as sir has
Okay.
suggested, that would have
Okay.
been a right step before giving IVIG.
Okay, I agreed.
So
Now-
there may not be MIC, but some kind of immune dysregulation is going
Sir,
on.
in spite of giving IVIG, we didn't see any response in a fever. The fever was persistent. Now again, after giving IVIG, the counts have climbed up like 3,100. Platelet all the lingering at the same 69,000, and her ferritin was rising like 5,200, and SGPT was around 70. Rest of the systemic screen was normal. So at this point, again, what should have been done in this case for as a evaluation, or should we have waited? Because still after giving IVIG also, the fever was persistent for almost 48 hours.
The course would have been the same even without IVIG. This is my firm
Yeah,
belief.
that is true, sir. In retrospect, like at this point of time, we thought like that only. IVIG has not helped at all.
What about oxygen dependency of the child? What about general toxicity
Sir, hemodynamically, the child was stable, like her blood gases and everything were normal.
and oxygen dependency?
Yeah, gradually we could decrease the oxygen support.
So
But
child is
the only thing is that her fever was persistent and her counts were coming down and ferritin was rising gradually.
also.
IV sites
CMA.
were clear.
So labs
IV
were
sites were
good.
clean.
Labs were good and labs were bad and patient was good. Is that?
Absolutely. Yeah.
No, sir. Patient was having fever continuously, sir. Means
That doesn't mean that.
But apart from fever, other parameters he was improving. The IV sites were clean, I suppose.
yeah, yes, sir. Yes, sir.
Was this IVIG related fever?
How
No,
many
I
days
mean-
by this time now? How many days of fever by this time in the second episode?
Sir, almost 8 days are over. 7 to 8 days are over, sir.
I would definitely do a bone marrow in this.
Yes, sir. Yes, sir. So now,
Just to complete the list, have you done GLAFB, Mantu, in this child?
yes, sir, we did CT scan also, and we did GLAFB also before. Like next step, what we are think of giving steroids.
Pramod, that GLAB would be only just to complete the list.
Complete.
But
Yeah. More
looks
than that.
looks
It's not a primary case to
almost
suspect TB at all.
almost unlikely. I mean,
Sir, now considering steroids, what precautions or what thing which we should do prior to starting steroids, or should we consider it or not only?
you
Means
should not
in
consider.
case
I
after
don't
giving
know.
IVIG, her fever is persistent and her counts are leukopenia, means she is having pancytopenia. I will like to say, like all 3 cell lines are going down, ferritin is rising up.
Only bone marrow, not without bone marrow, but I won't go ahead with steroids at all. If at all thought of, then I will do bone marrow and then go ahead.
Sachin,
See,
in
look-
this, yeah, in this patient, I think the child is overall improving clinically. I think my option here would be to wait and watch for another 2 days to see how the child is responding, rather than doing anything else. I agree with you that it's little stressful in private practice when the patient is under you for so many days and everyone is waiting for answers. But I think the time will only give answer. Like Abba Saib said right in the beginning of the discussion, that many of these patients, the time is the answer. So I would have waited for 2-3 days more. And
About life history of adenovirus, it is known for extended manifestations, including fever which crosses first week. So up to second week, you can get a fever ongoing in adeno. So there is no need to hurry about anything unless the child is worsening too much.
Actually, our concern was her other parameters like inflammatory markers were increasing, her platelet counts were going
All are
down.
immaterial. All are
And,
immaterial.
I don't agree.
Sir, because then there is no point in doing those investigations, because these are the things which we need to follow. Means
So this
at the
is,
same
this
time,
is
your
the
patient
pattern what we do. What we do up till now by habit. This is the pattern. In 3 days we don't get response. We think of something else. You should look at the natural history of the disease which you are having. Without that, you should not go ahead with next line. That will put you in fix.
So, sir, we decided to go ahead with steroids after doing bone marrow and CT. And we started her on methylpred, and she responded well to methylpred. After giving second dose, almost her fever has disappeared. And her counts has also shown improvement. Like platelet count has increased to 1,89,000. WBC count is also showing increasing trend. And her fever also subsided. So I don't know actually whether means looking at an entire thing, problem analysis and solution. So I just need your expert opinion, like whether we are dealing with HLH or it was just a thing which is associated with adenovirus.
You did the bone marrow?
Yes, sir.
What are the bone marrow showing?
So it was HLH like
Don't
picture.
expect anything.
There was a HLH picture in the bone marrow?
Yes, sir. Yes.
Then I think you are justified. You are all of us agree to disagree, but I would have gone the way what Sachin has done, definitely. I would have done the bone marrow that's shown, then I would have gone with it.
So actually, and after giving steroids, also inflammatory markers are coming down.
It could be natural resolution of the adenovirus itself.
Precisely.
Sir, but looking at
so a question to the panelist: how long is the natural course of adenovirus fever max?
2 weeks.
Up to 2 weeks. 2 weeks.
So one would wait with the fever for at least 2 weeks. Is that right?
Adeno,
I would look at this as some this perhaps the adenoviral was a causal agent in this, leading to some dysregulation and prolonged inflammatory response, and which eventually recovered. He would have recovered even without IVIG and methylprednisolone. Was the bone marrow, flooded with hemophagocytes? Was it a true picture of HLH? Because as Pramod said, we very often tend to overdiagnose HLH these days. Hyperferritinemia is just not. Of course, he has protein creatinine ratio raised and he has triglyceride of 192. I guess it was done on before feeding.
Yes,
So there, it could have been, a mild HLH, no doubt about it. But I don't know. I would have waited for methylprednisolone, definitely.
Yeah, again, the thing is that HLH after infections is not a worse scenario. It is only with rheumatological disorders. MS is the life-threatening. We have seen so many HLH post-dengue. Many of them get well without doing anything.
Yeah.
By the time you think of
HLH.
intervening, they're resolved. So it's not scary or life-threatening every time. And you should not go ahead with thinking of HLH treatment proactively.
I want to make a comment, but before that, I think Ramakant wanted to say something. Ramakant, you had raised the hand. Ramakant?
Yes, sir. Thank you for noticing it. But basically, are we over correlating ferritin with HLH? There is a definite
non-specific acute phase reactor.
Ferritin, what they say, because hyperferritinemia many times is considered as a HLH, and many times hyperferritinemia is an inflammatory marker. And many times this triglyceride is just above normal. So there is a H score. Out of 7 criteria, at least 4 criteria should be fulfilled. And cutoff for ferritin is taken as 6,000. 6,000. They are saying that cutoff for ferritin, isolated ferritin, along with symptoms, you want to make it as a HLH. So are we really overdiagnosing HLH? I feel I do agree with Dr. Pramod Kulkarni. And many times what happens, other side is also true. What we are going to do, what we are going to explain. So academics and art, many times we are confused in that. So many times we err on the side of giving something. We err. I don't say we are correct. We err on side of giving it. But HLH should be, unless only on ferritin, we shouldn't be doing that. HLH has to be done. Secondly, for epidemiological diagnosis, we are having so much of a rampant outbreak in Southwest India, also in West Bengal, and the type 7 and 7H, which is really a very virulent adenovirus, which can definitely have such a high inflammatory, low respiratory, pneumonia, even empyema-like picture. So even epidemiologically we are having, so we will rarely say that this was a bystander. Epidemiologically, it was a
in the case of diagnosed pneumonia, clinical pneumonia, isolating adeno is equivalent to pathogen.
Yes. So
no, Ramakant, I think Ramakant, I will just agree to. I mean, I will disagree here. We will agree later on. I thought we always focus on investigations, but we are not considering here the clinical course of this child. 3 days primary illness, 5 days all right, and then 3 days secondary illness. So even if it's a new onset of illness with a localizing infection, I think we should consider it as a secondary bacterial infection. My final diagnosis would have been that. Whether there was HLS and all is, I think your point is well taken. You are in Pramod's point. Yeah.
Virulent adenovirus 7H is also, it is not the viremia which is causing all these symptoms. It is a NOD1, NOD2 receptors combination, and it is over immune dysregulation. Absolutely. And viremia. Why it is more virulent? It is not
but it is part and parcel of adenovirus manifestation. Yeah, pathogenesis
so
itself.
It's not the viremia. It is the immune dysregulation. That's why we are having so much multisystemic. So I just wanted to make point. We are definitely overdiagnosing HLH. There should be some cutoff, and elites can come up with the pediatric values of HLH for ferritin particularly. So in adults, they definitely say it is a 6,000 cutoffs. I don't know about pediatric HLH ferritin cutoffs, which we can definitely say whether it is a HLH.
It is 10,000 as far as I know.
There are no such standard controlled, proven cutoffs. For that matter, last year we had in the national conference, we had a huge discussion on dengue with ferritin levels. And if the patient is stable, even 50,000 ferritin may not be treated. That was the conclusion. Okay, so dengue in a various
So
levels.
selective diagnosis again.
No, what I meant to say, raising a point. So there are literature who says 10,000 plus ferritin is unambiguous. Okay, I mean it's kind of a gold standard. You can go for HLH, but now we have realized the dengue virus has a genetic complication akin to TNF alpha, and the stimulation is by virtue of that, not essentially because of HLH. So even at 10, 40, 50,000 is very commonly seen in dengue, especially in the secondary phase. So unless and until there is a serious associated multi-systemic deterioration, you need not treat it as HLH. That about dengue. But at the same time, not to forget the primary dengue can land up with A&E as a manifestation similarly, which can be absolutely life-threatening. So I think the decision has to be taken case to case. You cannot be having one single kind of a guideline of 8 points and 5 points to define a particular condition. The patient is deteriorating in front of you. What is important is to save the life. And in that content, at times you may be over-treating, which is justified. At the same time, if he's stable enough, as Sudhir said, fine, just give another couple of days. At the end, again, you will end up taking the same decision. Take the patient in consent, in a kind of a counseling and a good kind of a confidence, and then you can take that time. I think it's, as you said, all of us sitting here with the last hair and gray hair, it's easy to counsel the parent and they also listen to you. Those who are just into practice last 3 to 5 years, poor fellow has only option to shift the patient to Sudhir or to Vijay or to me. But I think that's kind of a age matters. You know what you said, time is the solution, Abha said. So that's what the time we have spent and we are getting the advantage. That's at times I feel.
Okay. So it was an excellent presentation from Dr. Sachin. It has given a great insight to the real present
There are
epidemic
a couple of articles in PLOS on hyperferritinemia, especially in relation to dengue. Please read those articles.
Yeah, I wanted to add, if the Abasa permits.
Yeah, please, sir, go ahead. Please.
Yeah, I agree with what Vijay sir has said. There is a good article with regard to combination of CRP and ferritin.
Oh,
it's a
Joe Carcillo. Miraz, that's a Joe Carcillo study. Joe Carcillo study very clearly states high CRP with high ferritin is a HLH. High ferritin without CRP can have the high chance of CRP. Only CRP without ferritin is infection. And both normal is normal. So that's a Joe Carcillo cross which is given.
Yes, so this is very good for all of us to go through the combination of CRP and ferritin in such situation. And it is good for making a decision. That was my point. Thank you for excellent discussion.
Yeah. Congratulations, Sachin, for a very beautiful presentation of a rare manifestation, what we can say, or it may be just a bystander. That is again going to remain for a debate. Now we move ahead for our second presentation from Dr. John. Dr. John, are you there?
Yes, sir, I am there.
Yeah, please
Dr.
share
John,
your screen and start.
Dr. John, kindly
before
how much time I have?
Yeah, you can just start, then we'll see how much time we can stay with you.
Okay, sir.
Depends.
Yeah.
John, Parda
present number is 63, 64.
Yes,
so it drops to 50. We have got enough time.
So my presentation is visible?
Yes.
Hello?
Yeah,
it's there.
So in very short notice, I have done this presentation. I have taken the 3 cases with the variable presentation of adenovirus. So it is from Medicover Hospital, Navi Mumbai, which is recently opened. So case 1, 1 minute. Case 1 is a master Riansh, who is 1 year, 6-month-old male child admitted in pediatric intensive care unit of Medicover Hospital on 5th February with a complaint of fever and cough since 8 days. And initially the cough was dry in nature for 1 or 2 days, and then it became a wet kind of cough. And the fever was intermittent, moderate to high grade fever, for which they have went to local practitioner in Bangalore, and he received 2 to 3 days of syrup augmentin with a symptomatic treatment. Child started to have breathing difficulty since last 2 days before admission. So So on admission in ER, he had child was quite irritable with drowsy, tachypnic. The RR was in between 60 to 80 per minute with a retraction, suprasternal, mild suprasternal retraction and subcostal retraction were there. There was a tachycardia, heart rate of 140 per minute, bounding pulses. O2 oxygen saturation was 85, and on up to by NRM mass, it was coming up to 98%. And he had a bilateral crepitation as well as wheezing. On per abdomen examination, liver was 2 centimeter palpable below the right costal margin. Probably it was a push down liver. On investigation, the chest X-ray was suggestive of bilateral pneumonia. I have mentioned the X-ray on admission. And in his initial blood reports, they are suggestive of viral etiology. So on the day of admission, his hemoglobin was 11.6, RBC count was 4.7 into 10 raised to power 6. Platelet was 1.1 lakh. TLC count was 4,800 with neutrophils of 50%, lymphocyte of 44%, and monocyte 6%. And CRP was 8.1 on that.
John, your
on the
slide
day
is
of
not
admission.
moving. John, your slide is not moving. Or are you displacing your slide, or you just managing? Because we can't
No,
recollect.
no, sir.
Oh, can you please repeat those numbers again?
Yeah, I have not mentioned the slide about CBC
Okay.
because I made in very short duration. So HB was 11.6, sir. TLC count was 4,800. RBC count was 4.7 into 10 raised to the power 9. Platelet was 1.1 lakh. Neutrophil was 50. Lymphocyte was 44. Monocyte was 6%. And the CRP was 8.1 on the day of admission. And his HGPT was 117, HGOT was 417. Alkaline phosphatase was 82. His serum albumin was 2, and serum globulin was 1. AG ratio was 1. And his burn creat was normal. B1 was 7, and creatinine was 0.3 milligram per deciliter. And we got a PT-INR report after the 6 to 8 hours, where PT was prothrombin type was 28.5 and INR was 2.3. So we can see here on the day of admission in emergency, there was a bit left-sided haziness, as well as there is a right lower zone haziness also. So child was quite tachypnic. And on same day, we suspect that it could be some kind of viral etiology. So we send a sample for a viral PCR, and we come to know it is adenovirus. So in a view of tachypnea and retraction, a child shifted from emergency to PICU, and we put on the triple HFNC. During PICU stay, he had a continuous high-grade fever spike, which was 103, 104. Like that. And there was a tachypnea and worsening distress on HFNC on higher setting. We went more than 60% if I have to 60, 70, 80 gradually, as well as we increased the flow with a 2 ml per kg max. And in spite of on higher flow, child started to desaturate after 24 hours. And hence child was intubated and put on a mechanical ventilation. And child was a little bit puffy, so central line insertion was done, and we thought that there would be a requirement of prolonged medicines. So we inserted central line, and urinary catheterization was done because child was sedated on ventilator. So we make him sedated and paralyzed. He developed sudden pulmonary hemorrhage and bleeding through through ET and nasogastric tube, and his blood investigation picture was suggestive of DIC. Why I will say, because after 24 hours, again we have repeated, once his distress start to increasing, so his hemoglobin was 10.9, which was initially 11.6 on admission. The platelet count suddenly dropped from 1.1 lakh to 44,000. TLC count was same, which was initially 4,800, and later on after 24 hours it was 4,000. While differential counts were also same. Neutrophil was 63, lymphocyte 24, and monocyte 13. And as the child was worsening, child was becoming breathless, and we try to do other things also. So child was going in hypotension at that time. So we did an anti-pro-BNP. It was 34,733 with a raised hepatic enzyme. So we did a bedside echo, and echo report was suggestive of dilated right atrium and right ventricle, moderate global hypokinesia with a moderate pulmonary hypertension. So he developed hypotension suddenly, for which he required multiple fluid boluses with inotropic support in the form of adrenaline or noradrenaline and highest doses. In view of persistent massive pulmonary and GI bleed, he received FFP. When he started to have a bleed, we have given other treatment also, vitamin K as well. Once we got a report of PTINR, we already has started with the vitamin K and tranexamic acid. After that, and in her persistent massive pulmonary bleed and GI bleed, he has received FFP, platelet, cryo, PRBC, and other symptomatic treatment. In spite of that, the bleeding was not under control. It was spontaneous bleed. In spite of that, in spite of giving a fluid boluses, higher inotropic support, that baby was not maintaining blood pressure. So, and unable to maintain oxygen saturation. In spite of 100% oxygen saturation on higher pressure, the SpO2 was 45 to 70. And serial chest X-ray was suggestive of worsening of underlying lung pathology. The patch has increased gradually, that left-sided and right-sided patch. So in spite of all resuscitative efforts, I was unable to survive and declared death on, he was admitted 5th and he died on 7th in the afternoon. So it was kind of complicated bilateral pneumonia, probably due to the adenovirus with a DIC. D-dimer voice also was 12 with a severe pulmonary hemorrhage, myocarditis, hepatitis, ARDS, and shock. So it was kind of inotropic and fluid resistance with a severe pulmonary bleed, and which is deteriorated within, I think, 24 to 36 hours.
John, that was the only prothrombin time, or you repeated it?
I have repeated it, sir, on admission, but I got a report late. On the day of admission, it was 28.5, and INR was 2.3. So
that was the only prothrombin time, right?
That is what on the after 8 hours of admission, first prothrombin and INR time, and once child we put on the mechanical ventilator and we put a central line. Again, we have sent the coagulation profile. The PT has worsened to 40 from 28 to 47, and INR from 2.3 to 3.8 on vitamin K.
And his liver enzymes were not very high.
HGPT was 117, sir, and HGOT was 417 with hypoalbuminemia. Serum albumin was 2.
And he had only pulmonary hemorrhage.
Severe pulmonary
hemorrhage. No other bleeding sign.
Pulmonary and GI hemorrhage, both. And it was old blood, sir. When
GI hemorrhage came as a terminal event?
Pulmonary hemorrhage came as a terminal event.
Then this GI hemorrhage, when did he have GI hemorrhage? When he was
initially we haven't put RT. We intubated him. That time he was maintaining for 1 or 2 hours like that. And that time we also insert the RT. Then we found that through RT, it was old blood was coming. It was a black in nature. That was not fresh blood. A child was in respiratory distress. We had kept him NBM. So this was a kind of severe kind of thing which had presented adenovirus pneumonia in this kid.
Yeah,
was this adenoviral myocarditis to begin with?
Yes,
it was there.
Yes.
Hypokinesia with dilatation of right atrium ventricle.
Yeah. So that was a little bit of unusual, not unusual. That
No,
severe
this is a
presentation.
known fulminant case of adenovirus, and it is well known to occur in immunocompetent child as well. That is peculiarity of adenovirus.
So this was a severe presentation of adenovirus.
What else could have been done? Could we have done something else?
That was I was thinking, sir, where I have missed, but a child deteriorates so suddenly, so it had not given us a time, because of, in spite of giving a cryo, twice FFP, vitamin K was going on, injection tranexamic was going on, everything was going on.
Then on immunological side, would steroids, methylpred or IG would have helped this child?
to take a decision within 24 hours to start IVIG and steroid is very difficult in such kind of scenario.
Yeah, I understand.
Because
Dr.
we are
Ramakan?
managing the
Pramod,
bleed.
how common is adenoviral myocarditis? Not a very
Common
common
per se,
virus.
but it's a known, one of the
It's,
known.
yeah, theoretical. Yeah.
Yes.
Can affect any system.
Yeah.
So
I think Ramakan want to make some comment.
Well, is
Ramakan?
this definite DIC?
I think he has gone through all catastrophe, which ultimately culminated into DIC like picture. And I don't think you could have done anything more than what you're doing. I firmly believe. You've done the max that you could.
Ramakan wants to say something.
There two things are copies doing in this patient, whether it will be able to attribute it is really adenoviral. And secondly, this is very catastrophic cardiopulmonary syndrome with hemorrhagic, because pulmonary hemorrhage is not terminal event. It was a presentation on when patient died, before that 2 days at least prior. So how common is virus in our country? How to diagnose it? And whether adenoviral copies, number of copies will help us in attributing this to the adenovirus.
The viremia is not reliable. It is the virus demonstration in end organ. If we had chance of autopsy in this child, a liver biopsy or myocardial biopsy would have really clinched the diagnosis. Viremia per se is not sufficient evidence.
In fact, I think I would, at least up-to-date mentions that finding PCR, adenovirus PCR from sterile sites is a, kind of a clinching evidence for attributing the cause to adenovirus. Sterile sites, not from nasopharynx. So nasopharynx can be like what we're discussing in the last case, bystander or viral shading, or it can be associated. But so viral copies is one, I think, good idea that Ramakan gave. But blood PCR or PCR from CSF or any sterile site, if you get, then I think it's more likely to be causative organism rather than associating organism.
Pramod, why are you saying so? Because if you look at the reports on pseudofovir or immunoglobulin immunocompetent children with adenovirus, many of the reports talk about quantitative PCR in blood, adenovirus blood.
Absolutely.
As monitoring.
No, even
yeah,
for
but it is diagnostic. No?
Even for diagnosis. Even for diagnosis.
So I have two more cases with
Dr. Minasek also wants to contribute something.
Yeah, I wanted to know from the esteemed panelists and the seniors that right now I have a case, 14 years old male child has had influenza-like illness 1 week before, 14 years old, 52 kg, presented as cardiogenic shock. We managed the shock, ejection fraction 20%, and as you know, we did the biofire, turned out to be adenovirus. So we don't know what, like whether it is adenovirus myocarditis or what. We really don't know whether it is cause and effect. Yeah, I mean, I want to learn from all of you what it is.
Send his blood adenoviral copies.
Yeah, quantitative PCR.
Blood adenovirus.
Quantitative PCR.
Okay. So what do you think, sir? It is causing the myocarditis, this particular case?
Yeah,
you said flu-like illness. I mean, and child, 52 kg, 14-year-old child is an obese child, right?
Yes.
So obese children in general, they have obesity per se is an adverse contributor. But yes, I think adenoviral copies is worth sending.
So Minaz, I can contribute a little bit. I mean, adenovirus, as we know, is known to cause myocarditis.
Okay.
And so I think, and in any outbreak, when there is a massive outbreak, we will see all variants of the same illness. So remember, when we had severe dengue illness, we had dengue myocarditis, dengue with leukocytosis, dengue with encephalitis. So I think it's the combination of genetic susceptibility of that individual, which is difficult to prove, and onslaught of viruses in the community. And you will have such rare manifestations like HLH, myocarditis, which is coming up. But these are not the common manifestations that we pediatricians in office are seeing. We pediatricians in office are seeing febrile respiratory illnesses going on for long period of time. Yeah.
Thank you
Sudhir,
so
would
much.
you use immunoglobulin or cidofovir in this 14-year-old child that Minas is handling?
No, I think the indications, I mean, I have only read about it, never used, but indications for antiviral drugs are very, in a known immunocompromised, say bone marrow transplant, or if I've got a child with liver transplant who has this, then I think it would be kind of worth it. Keeping nephrotoxicity in view, I will read again before using it, but that's the one.
Immunoglobulin, IVIG?
Immunoglobulin we tend to use very easily, and the books, some of the studies mention that usual immunoglobulin has a good antibody for pooled adenovirus, but whether it acts for adeno-specific, that serotype, we don't know. So, I mean, as a last resort, how we tried in the previous case, we might give, but again, not really I mean, strongly supported by scientific evidence. I wouldn't.
Being a acute myocarditis, don't you think you would have used IVIG, irrespective of the underlying pathology?
Huh.
It was acute myocarditis. I'm sure your cardiologist will definitely recommend to use it. I mean, in general, cardiologist confirming it's not an old standard, it's a new onset acute myocarditis. I'm sure that's one thing which everybody uses. So whether it's adenovirus or something else, perhaps people have used it.
Minas IVIG दिया है?
हाँ दिया है सर.
अच्छा.
दिया है सर. उसके बाद में उसका next 24 hours में उसका inotropes कम हुए हैं and his heart rate has come down. But then it was really a challenging case. 14 years old coming like cardiogenic shock with ejection fraction of 20% only.
We have a H3N2 with a ARDS going into cardiogenic shock with a 20% ejection fraction. So that's a confirmed H3N2 at the moment.
So these are real challenges which are nowadays coming up with, sir. I mean,
Mahesh, with cardiogenic shock, how would you be sure about ARDS or the sequence of events?
No, he started with ARDS and then subsequently, after 5 days, he landed up with a sudden drop in the contractions and became pulseless almost.
Excellent presentation, Dr. John. John is prepared with 3 cases, but as we have already decided that when our count will go down 50, it is now 45, and we have already surpassed the time. It's 11 o'clock. So it is always better that you stop on time. So Dr. John, for those who don't know him, he has joined Medicover, and now he is in charge of that intensive care unit, pediatric intensive care unit. He has worked under Dr. Mamta Manglani at Sion Hospital. In between, he was intensivist at Apollo Hospital also. So excellent presentation, Dr. John. And as IIP Raigad, we will definitely like to hear you one more time about the remaining cases. But what Dr. Sane sir has brought the point, I'll take only 10 minutes from now, because this is a forum of more of a general pediatric practicing pediatricians. And the 2 cases which we have seen, they are all intensive based cases. What are the challenges which we face in day-to-day management of the cases, that what sir wanted to actually bring out. And the similar case, like a fever persisting for 6, 7 days, 8 days, 10 days. We are listening from others, we are coming across the webinars, we are seeing, but when actually you are treating a patient, so how you should go? A patient who is presenting to you on day 2 of a fever, and now he is following you, he is a quite loyal patient, and he, as we have already lost our hairs also, so he is believing you also. So how you will counsel to the patients, day 2, day 4, day 7, fever is still not going. How you will go and how you will monitor and how you will treat this patient of a 6 to 7 year old kid who is in fever with cold and cough, and now presented to you on day 2 with a typical viral symptomatology. He is coming to you after 2 days, again after 2 days, and now day 7, still there is no fever is not going down. So just Dr. Sudhir Sane sir, you guide on this.
John, can you please stop sharing?
Yes.
So I think when this child comes on day 2 of illness, the first thing that we just discussed, I think, touch the basics. We are in the outbreak of adenovirus, but not only adenovirus. We have influenza going on. We have occasional cases of RSV. We have COVID coming up. And we have some occasional cases of measles still lingering. We have Coxsackie virus, Harpangina, and all of you must be seeing variety of patients. So just don't jump to the conclusion that this is influenza. I think try to take relevant history. And few of the histories that we should take is, are there any febrile illness in the family? And I think many of these patients have some or the other person having febrile illness in the family. Then ask for red eyes in other members of the family. If there is conjunctivitis in other members of family, then it can be sometimes a kind of kind of indicator to adenovirus in this child, because as we know that pharyngoconjunctival fever is one of the manifestations, but remember that it may not occur in the same child. One of the parents may be having conjunctivitis, and we have seen this very often. So on day 2, we would give them symptomatic therapy, look at the interfebrile activity, give them danger signals, and call them for follow-up. I would really avoid doing any investigations unless there is a kind of high risk patient for influenza in the family. So I think our history taking skills have to be now more clear. We should ask for any person more than 65 bypass in the house. And if there is so, then I think we should, if facilities are available, then I would do influenza panel test for in such a patient, because it has a definite significance for treating this child and other members in the family.
When he has come for first contact, a 2 days history of fever, we all know that we are not going to prescribe any antibiotic. We have thoroughly examined, throat is normal, chest is clear, there is no tachypnea, and patient is sent on only paracetamol, SOS mefenamic acid. He comes back after 2 days. Now there is rhinorrhea which is persistent, cough has increased, and now there is some follicular tonsillitis. How to guide with it? Dr. Sane, sir, you continue, then I'll come to Evle, sir. Yeah.
Okay. So I think again we will go for the trend of the fever. How is the trend of the fever increasing? Is the toxicity is increasing? And interfebrile, how is the child?
Interfebrile period, child is normal, toxicity is not there, appetite is good, but for first examination, tonsils were normal. Now tonsillar, there is a follicular tonsillitis.
Absolutely. And the trend of the fever is worsening, or it's the same, or
same,
almost the same.
One not two, 2 to 3 spikes per day.
So on 4th day of fever, 102 with follicular tonsillitis, I would start this child on amoxicillin at 40 milligram per kilogram per day. I would carefully look for rhinorrhea, because presence of rhinorrhea would tell me that probably there is something else, not typical streptococcal pharyngitis. But we would really, if there is no rhinorrhea and only tonsillar congestion, tonsillitis, then I will give him amoxicillin.
Yeah, the same which we, Dr.
Sudhir, we saw a lot of adenoviral infections with tonsillitis and tonsillar exudates, which look like tonsilloliths, not like typical your group streptococcal tonsillitis.
I agree.
So initially, yes, we using Centros criteria, we started a couple of them on amoxicillin, but off late, I must have seen at least 4 to 5 with clear exudates where we have not started any antibiotic. Of course, they have other features which suggest a viral illness. These days one needs to be a little careful of starting amoxicillin, only looking at the tonsillar exudates.
I understood. So absence of cold. And of course, we know that adenovirus can cause adenopathy also. So submandibular adenopathy with tonsillitis can be also, but knowing fully well that it is adenovirus, I think still it is justified to start amoxicillin on 4th day of illness if there is no clear rhinorrhea in this child. I mean, let all the other panelists and Abba Sahib can comment on that, because never forget that there are multiple illnesses occurring. Missing a streptococcal pharyngitis would be, it's not a great thing to happen at this age or this stage of our career. And that's why we would give amoxicillin in this child.
Now I'll come to Dr. Mohite sir.
I think in this, I will definitely give a significant weightage to a significant throat pain, which I don't see that often with all the viral pharyngeal tonsillitis, but I'll definitely get with bacterial tonsillopharyngitis. Throat pain, swallowing difficulties, pain, I think goes
50% of the patients will have throat pain, 50%
not much. I mean, go with the severity. Bacterial
No, but
tonsillitis has got a
I,
severe pain.
I disagree, Mahesh. I'm sorry. But one of the criteria for diagnosis of influenza-like illness is sore throat. And sore throat means throat pain. And second thing is Coxsackie virus harpangira, significant severe throat pain. So you have viral infections which are pharyngitis, which are painful. So pain would not, kind of differentiate between bacterial and viral. So I mean, my take on that. Okay.
So there is a subtle difference. The group A streptococcal pharyngitis or tonsillopharyngitis, they would present with throat pain, and adenoviral tonsillitis will also have pain, agreed. But as a presenting complaint, they would say घशात दुखते आणि swelling आहे, jugular directly lymph nodes and large. That does not happen with adenovirus. They will have fever, they'll have red tonsil, they will have tonsillolith-like looking exudates. But the presenting complaint is not throat pain by and large.
I agree.
They do have throat pain, but that is not the main predominant presenting complaint.
Few of the patients may have, few of the patients may not have. But if somebody has got a throat pain significant, then I think Dr. What Moite sir said, it will be more towards a bacterial etiology. That is definitely well taken. Now the same patients, Dr. Evle sir comes back after 2 days on amoxicillin, compliant treatment, there is no change in fever. Now we examine and use there is a membrane on a tonsil, a classical membranous tonsillitis. And now the mother says that patient has started snoring, and then there is a difficulty in breathing. But when he's awake, there is no difficulty in breathing. There is no difficulty in swallowing. Hydration status is normal. Interfebrile period is normal. Now, how to go about it? Now we are seeing a classical membrane on a tonsil.
So two things. It is very uncommon for a group A streptococcal pharyngitis not to respond to amoxicillin. One. Secondly, let us not forget EB viral infection also, which comes with tonsillar exudate membrane and snoring. And typically they will have, apart from anterior, they also have posterior cervical lymphadenopathy. Their face looks a little puffed up. So EB virus is, recently we saw 2 cases of EB virus in the last 15 days. So EB virus is something that is very often not thought of, because usually tubular vision होऊन जातं, काही आउटब्रेक आला की आपलं तेच बघत बसतो आपण. And as Sudhir said, at this age and stage of life, one would not like to miss out anything.
Yeah. When we entertain a diagnosis of EB virus infection, most of the times we see that there is an exudative tonsillitis, and there are so many other features like you can get jugular diagonal lymph nodes and even posterior auricular lymph nodes. So, and patient has got a typical of a snoring basically. But the same thing,
palpate for the spleen.
Palpate for
gently, gently palpate for the spleen. Often spleen is palpable.
And send IG, I have EB IgM.
Send EB IgM. But now this patient has not responded. Any therapeutic intervention you want to do at this present?
No, if it is EB virus, you will continue and you will just counsel the patient and keep under surveillance. Nothing else.
Okay, Dr. Kulkarni sir, the 4 types of pharyngitis which you commonly see, that is streptococcal, then adenovirus, and then our diphtheria, and then infectious mononucleosis. Kindly give us a 4 classical differentiating markers that this, if it is there, it is most likely to be EB virus, or if it is there, streptococcal, or whatever it may be. Just elaborate on that and give some 4 or 5 each every point, whichever category is saying that this goes in favor of this diagnosis.
Let us say again the same thing. You are asking for clinical, reliable clinical markers of a microbiological diagnosis, which is against science. That's why we have all these scores, and not single parameter of this score is reliable for individual diagnosis. All these scores have to be taken collectively, noted down on paper, and then thought of it. Again, it is suggestive or predictive. It is not diagnostic. So no clinical feature can differentiate between these 4. There are few pointers apart from the classic ones. Older age group will go in favor of bacterial tonsillitis. Day 1 presentation of fiery red tonsils is more of a group A streptococcal. Younger children, of course, towards viral. The classic we know, Centaur score, all those things. Significant adenopathy, splenomegaly, and snoring, adenoidal enlargement, or facial puffiness will go in favor of EBV. All these are collective. There is not a single marker will tell you one particular diagnosis. It is against the science of clinical diagnosis of microbiological condition.
So in a EB virus and in adenovirus, both the cases will have exudative tonsillitis, both the cases will have snoring, both the cases will have persistent ongoing
Again,
fever.
I said.
So what will come to
Snoring
your
is
health?
just adenoidal enlargement or nasal block.
But it is
Nothing
a
more than
symptom.
that.
But it is a symptom of a concern, because that snoring can happen in a membranous tonsillitis, which will progress over a period of time, and you may miss a diphtheria, which is a life-threatening disease. Once in a while, may not always, but it could happen. So that's the reason, if somebody is snoring, which was a normal to begin with, fever was there, snoring was not there. Now snoring there, and patient have started worrying.
No, Abba, I won't agree with you. Commonest cause of snoring is adenoidal enlargement or nasal block, which is very common with common viral infections inducing immunological response and adenoidal enlargement. So I will not think, if the child is unimmunized or if the child is not that toxic, and there are corroborative evidences, then and then you will think of diphtheria. And why to think of diphtheria? Do a swab. First thing, take a membrane and send it. That is the best way to look for a diphtheria.
One early clue for diphtheria is very early in the course of enlargement. They have nasal twang and regurgitation, which is almost not there in any other kind of infections.
Of course,
Diphtheria.
it will be
One second. And also,
I don't agree.
Okay, and also diphtheritic tonsillitis are rarely highly febrile. They have bull neck, they have large adenopathy, but not highly febrile. No, now one thing that I think we all have learned, I think Abbas, we have also learned over a period of time, that classical presentations are classical, but most of the times they remain in the textbooks and they have to be taught to our students. So when sitting in the clinic, we get so many, milder atypical presentations, and it's our skill to diagnose them. So I think that is what. Yeah, Mahesh, you wanted to disagree.
Yeah, about yeah, definitely. I think we enjoy that, Sudhir. So
Yeah,
basically, nasal twang is a manifestation of post-diphtheritic neuropathy.
No.
Yeah.
No.
I can give the reference.
I can give you the reference. 100% it's a manifestation of post-diphtheritic neuropathy, but nasal twang occurs because of local action of diphtheria toxins on the palate, and it is there in the first few days of illness. And not only I can give you reference, we have currently seen one child of diphtheria.
And the second point about they are very toxic, honestly, this we have experienced as well as we have read also, that not essentially every patient who comes with diphtheria is very toxic.
Absolutely.
We have proven that. Okay, so let's not go with the notion that this is not a toxic, so unlikely.
No, in fact, I was saying.
Yeah, leathery patch, which is not like white and streptococcal, leathery patch, shaggy patch, be careful. And ivory patch, I think you rule out diphtheria. My take is every patch, when you say, unless a multi-system kind of clean everything like EB. But if you see a diphtheritic kind, suppose suspected patch, always send a smear. And again, as Dr. Pramod said, you pull out the patch, be careful, because that is known to be releasing a lot of toxins while pulling it out. Excessive bleeding is also known with that. So whatever little thing you can just pull out and send it to a reliable lab. That's the way you'll go.
So another comment is the exudative tonsillitis that we are seeing in this adenoviral outbreak was not so common in the past. We used to see, okay, maybe it is the sheer number is very high. That is why perhaps we are seeing more, but definitely even then a little more patients. I mean, it is occurring a little more commonly than before. That is one. And secondly, finally, Abba said, there is something called gut feeling which comes with age and experience. And of course, you should be open to learn and correct your own self. Otherwise, it will lead to bad constipation or diarrhea.
Yeah. And one more thing, one more thing. As we are discussing, there are certain cases which S3N2 or whatever flu are coming positive. So in a setup where we are not investigating, but when it comes positive, you upfront start with oseltamivir. So clinically, which are the cases where you can start with, this is to Vijay sir, you start with this oseltamivir.
Our age-old classification into 3 groups still holds true. So test and treat. So you have any risk factor of developing a complicated influenza, or you have hospitalized children with severe respiratory infection, you would start empirically looking at the overall clinical picture. Or if there is, as Sudhir said, if there is a close contact in the family who is at risk of getting complicated influenza with a risk to life, you would empirically start such a child on anti-flu medicine and definitely ask him to observe all droplet precautions. Otherwise, on an OPD basis, usually you don't start anti-flu medicine empirically. And another point that even in the past, I used to think that anti-flu should be started within 48 hours and it has no role beyond that. But we have seen in practice, if the patient has persistent high fever and you make a diagnosis, you start anti-flu medicine and the fever breaks after within 48 hours.
So in a OPD, yes, sir, please.
Can I make one small point about
Please, please.
infectious mononucleosis versus adenovirus clinically? I think in infectious mononucleosis, there will be rarely multiple family members sick. In adenovirus, there will be multiple family members sick. So if there are multiple family members who are sick, then I'm not considering the infectious mononucleosis much. So other clinical picture remains same: snoring, adenopathy, patch on the tonsils, but multiple members, mother, father, some other child suffering, it's unlikely to be infectious mononucleosis. It's more likely to be adenovirus or any other flu-like illness.
So, yeah, so the discussion is like if you are seeing OPD case with a typical viral infection, not getting complicated, and fever is still running at the end of 6th or 7th day. As we know, oseltamivir works very wonderfully less than 48 hours. But is there any scope at the end of 7th day and 4 days of good antibiotic coverage? Can we add oseltamivir at that time? If yes, can we add basically? Dr. Vijay, sir.
So there is this is a very difficult question to answer unless you take into consideration the overall picture. It is generally not recommended to start anti-flu on day 7 just because the fever is not responding. You have to look at the other, clinical findings and maybe labs also.
Labs are normal. Clinical findings, there is no low respiratory infection, only persistent tonsillitis, persistent fever, and there is a rhinorrhea.
If there is no lower respiratory infection, I would still hold on to starting anti-flu empirically in such a child who has had fever for 7 days. No.
So, tonsillitis progressing, fever persistent, antibiotics day 4. Is there any scope of adding or changing the antibiotic?
No, as I said, most of the group as streptococcus would respond. If the child has not responded, think of something else. It is not bacterial tonsillitis, unless the child is developing some complication of bacterial tonsillitis.
Do we see non-purulent conjunctivitis in adenovirus cases?
Yes.
Is it common or
only red eyes, only sticky discharge? And another thing is, a lot of us are using antibiotic eye drops, which perhaps is not required.
Okay, but is it observed that only single eye is involved?
Yes, all sorts of things I've seen. Single eye, both eyes, only redness, non-purulent conjunctivitis.
And as
everything is possible.
And as I told you, in the family members also, may not be in the index case.
Yes.
Family member having red eye.
Yes.
And the other way also we have seen. We did a study on 10 consecutive patients where we diagnosed pharyngoconjunctival fever. And to our surprise, only 6 of them had adenovirus, 2 had influenza A. So, it's not really a kind of...
Absolutely. If you remember, the other day I showed a case where we thought of adenovirus, it turned out to be influenza, typical conjunctivitis and everything. And adenovirus can come without conjunctivitis also.
Yes.
Okay. This is the last question to Dr. Mahesh Mohite, sir. Clinically diagnose a case of adenovirus, the way epidemic is going on, or maybe a flu. Are there any clues that this patient may worsen in future? Otherwise, what will happen? You manage till 7th day and 8th the patient deteriorates and the whole blame comes on you. You keep saying that this patient fever will going to go down after 7 or 8 days. So are there any clues by which you can assure parents that don't worry, this patient is going to be better?
Now, in a present time, what are the progressions and complications that we have seen from adenovirus? That's important to note. Though the literature mentions there are cases of neurological complication, we have, at least I personally have not seen, maybe one early encephalopathy, otherwise no significant. But what we have definitely seen is a progressive lower respiratory tract infection. And those, once they catch up, they will take long time. Plus, they are likely to progress in spite of whatever you may do. So if you happen to see documented lower respiratory tract infection with early tachypnea, I think don't wait for this patient. You may transfer because this patient will require high flow cannulas, oxygen, maybe SOS ventilation, and rapid deterioration. Barring that, just a conjunctivitis, just a throat pain, fever going on, I think you can definitely hold on, whatever counts there may be. So if you definitely get to see a multi-system presentation, especially a progressive respiratory manifestation that all of us are seeing at the moment as a Harbinger, occasional one comes with myocarditis. That's unfortunate if it happens, because that can happen on day 3 and that can happen on day 10 also. But generally for a regular take home, I would say one with a lower respiratory progressive manifestation, you better shift this patient because he can go in any way.
Okay, thank you, sir. Now,
Abba Sahib, I agree with Mahesh, but remember what he said, progressive. They usually give you enough time. Unlike they don't crash in 24 hours.
पॅनिक व्हायचं काही कारण नाही.
एखादा पेशंट असा जॉनने दाखवला.
होणार.
Usually
एखादा
you
होणार,
get
एखादा
time.
होणार. True.
Question to Dr. Vijay Evle sir, Sane sir, and this thing. What I feel, the adenoviral strains which are causing gastrointestinal infection or pharyngoconjunctival fever are less likely to have very florid or moribund course. What Dr. Mohite sir has said, the respiratory infections most of the time might be caused by virulent strains, and those need to be observed. So pharyngoconjunctival fever or intestinal infection with respiratory infection less likely to have a very moribund course. And secondly, we see more of a unilateral conjunctivitis, pharyngoconjunctival fever. Unilateral conjunctivitis is a more common adenoviral infection. And we can definitely differentiate pseudomembranous tonsillitis of infectious mononucleosis. We have seen in our residency days diphtheria in 88, 89, in 87. And that picture is etched on our mind. Very rarely we can mix the diphtheritic tonsillitis from the pseudomembranous tonsillitis of infectious mononucleosis. And I agree with Sane sir that day 4 tonsillitis, if there is no family history of any person having similar history of fear or like that, then it has to be treated with amoxicillin considering bacterial tonsillitis. This is my personal opinion. This is what I think.
Yeah. Okay, now we have
just one.
Just
one comment prior to that. One thing which is not discussed perhaps, and I definitely want to stress, we have definitely documented cases of adenovirus. To our surprise, those pneumonias which progressed, we have seen about 10 cases, of which 3 developed on day 3, day 4, massive empyema-like presentation. One of them came with respiratory failure, and that was very rapid onset. It was referred from the Saroja-Khargar belt. Other one developed it on the day 9, day 10 of the disease. And third one again came on day 4 of the disease. And we trained in the first patient almost 400 cc of pus. It was something like a 800 cells with neutrophilic, with exudative kind of a thing, confirmed to be adenovirus. Other one almost 200. So this is unusual presentation of adenovirus, which so many years we have been considering that viral pneumonias won't give rise to empyema-like presentation. But kind of a message that if you get an empyema, don't rule out, still it is underlying virus. And don't disregard that presentation.
But Mahesh, it is unlikely that it is pure adenovirus which gives rise to empyema. I mean,
it has to be bystander. Why should viral illness lead
or
to
superadded infection? Because virus will not give rise to empyema. No?
So two things about it. One thing is that there is a saying that adenovirus fools. Adenovirus comes with leukocytosis, very high CRPs up to 200. But Mahesh, one question is, pus cells of 800 is not empyema. It's pus cells if there are more than 5,000, if I say correctly, then it's a diagnosis of empyema. I think 800 is not empyema. 800 can occur in any parapneumonic effusion and anything. So if you say 800, I wouldn't call it as empyema.
I'm not aware if there is any cutoff number given anywhere with a reference, honestly, but I'll check on that. But yes, I'm not aware of such kind of a cutoff given for the number of cells to diagnose something as an empyema.
Yes,
it's all exudative with a neutrophilic count. That is an empyema that I understand. I understand 50 and 100 cells I will not take, but I'm not very sure whether there is any kind of a cutoff. It's a low LDH, high LDH, those kind of cutoffs used to be given in the past. But early streptococcal pneumonia, empyema also can be having very low count, and I have definitely, but I'll check on that number if there is such kind of a reference available.
There is a reference, and we will check on that, and we'll come back. Yeah.
Yeah, so we come to the end of the CME. Excellent presentation from Dr. Sachin and Dr. John, and nice discussion by panelists Dr. Evle sir, Dr. Sujit Sani sir, Dr. Pramod Kulkarni sir, and Dr. Mahesh Mohite sir. Thank you, Dr. Ramakant Patil, for giving me opportunity. Thank you, Vikas, also for giving me opportunity. Today actually is the birthday of our Neha Singh, who is the editor of Maha IAP. We all wish her a happy birthday because still it is half an hour to go. And now over to Dr. Vikas. Thank you so much. Thank you, my dearest panel. Thank you so much.
Thank you so much, sir, for this excellent conduction of the whole CME. There are very varied discussion was very beautiful, and initially it was very scary when Sachin and John presented, but Abba sir made it slightly easier. So he came down to the pharyngitis because listening to ventilation and IVIG slightly very heavy for the general patients, and we don't want the general pediatricians take this message that this is very scary disease and we're so much scared. Mohit sir has told me categorically that the take-home message should not be very scary. Only thing is that we should be very, very careful while handling our cases, and we should be very watchful. Before ending the presentation, one last word regarding the sudden surge of pertussis in this case. So how you are this question is to Sujit Sane sir. So this how to handle this pertussis cases.
Yeah, I mean, two things about it. That adenovirus is known to cause pertussis-like presentation, exactly like a pertussis-like cough, and that has been well described. But we all know, and I keep on reading in your chats also, that pertussis comes with, kind of spasmodic cough, which is increasing, and spasmodic cough in single inspiration, which is followed by acute inspiration. We all know that. The neonates can have different manifestations. A combination of leukocytosis, lymphocytosis, thrombocytosis, and low inflammatory markers like low CRP, low ESR would be a clue to pertussis. Within a small child, if there is a history of cough contact in adolescent, it would be really clinching. I think this is the way I go about in establishing diagnosis of pertussis. In some patients, we can do nasopharyngeal PCR also. Especially, I've done few in neonates where it's very important. And nasopharyngeal PCR comes positive in around 30 to 40% of clinically diagnosed pertussis in my kind of office practice.
Pertussis do not have very significant fever also.
Absolutely. So no toxicity, no toxicity. Post-measles, we have seen many patients with pertussis. I don't know what is your experience, that we have got many patients who had suffered measles about 1-2 months back, and now they're approved pertussis. So this kind of combinations, all of them are totally unimmunized, and there are belts in every city where this unimmunized population, I mean, there is a cohort of unimmunized population.
Sudhir, you are doing that infection lab PCR for pertussis using
infection lab PCR. And now, of course, that that respiratory panel, I think, also reports pertussis. But pertussis we get. And I think very, not uncommonly, we get pertussis PCR positive now.
Thank you, sir. Over to Dr. Ajay to give the comment.
Thank you, Dr. Vikas. It was really, as Dr. Vikas has put it, it was a very vast and profound discussion. Too profound in the beginning, but now in the end, we are on the same page. So I'm sure it has solved many more dilemmas in our minds than it has created. Okay, let us go to the vote of thanks. I would first like to thank Dr. Vikas More, sir, our president of Raigad IIP, for organizing such a wonderful CME of such a relevant topic in such a very short notice. And next, I would like to thank our moderator and the organizer, Dr. Abasai Patenkar, sir, who has moderated and managed the whole show so secondly.
Excellent. Very
excellent. Yeah, and I would like to thank Dr. Maha IIP President, Dr. Ramakant Patil, sir, for his blessings. Next, I would like to thank the speakers, Dr. Sachin Murade, sir, and Dr. John, for bringing forth such wonderful and varied cases, which stimulated the long and vast discussion. And last but not least, our esteemed panel of experts, our very own respected Dr. Mahesh Mohite, sir, Dr. Pramod Kulkarni sir, Dr. Sudhir Sane sir, Dr. Vijay Yevle sir. Thank you all for your valuable inputs and your feedback and your knowledge which you have shared with all of us. I think we should call it a day. Thank you all.
Thank you.
Thank you. Thank you very much.
Thank you so much.
Good